Now we will hear from Andrew Dreyfus, the president and CEO of Blue Cross Blue Shield of Massachusetts, one of the largest and most innovative not-for-profit plans in the country. As CEO, Andrew has steered the development of the highly regarded and now widely adopted alternative quality contract. He was a key contributor to the successful passage and launch of the state's landmark health reform law. The Boston Globe has called Andrew the last healthcare reform optimist. Maybe in Boston, but not in Washington. There's no question he's a visionary leader that is really driving positive change in the state of Massachusetts. And I'm proud to say that he is the vice chairman of NIHCM Foundation. Andrew.
Thank you, Nancy, and thanks to the NIHCM Foundation for hosting this event today. I'm from Boston, so I'm used to talking quickly, but I actually don't have as many slides as Dr. Conway had, so I'm going to speak a little bit more slowly. You heard about the work underway at CMS from the ACA, but focused on delivery and system reform. And in many ways, it parallels the Massachusetts story that I'm going to tell you about today. It's just that we got a 5-year head start. And by doing that, we've learned a lot, we've changed a lot, and we now have the most rigorously studied payment reform model in the nation. And it's not only attracted interest here, but actually around the world. We regularly have visitors from European countries who themselves are trying to think about payment reform. I just want to start, you see here on our coverage reforms, which passed in 2006, and you can see that health insurance levels in Massachusetts have been the highest in the nation. We now have what I call full insurance at the level of many Western European nations. This was the model for the ACA. There was a time where politically that was hard to talk about, but it's clear this was the model. And we're pleased that some other states are actually starting to catch up and improve their rates of uninsurance. Although we've made such progress on coverage, the framers, the architects of our state law, explicitly chose to delay looking at the cost issue, because for decades in the nation, both in states and in the country, the coverage progress was held hostage to costs. Everyone said, well, we can't expand coverage until we control costs, and so coverage never got expanded. And so after the law was passed, those of us in Massachusetts started to turn our attention to cost. And we knew at Blue Cross that the most powerful lever we had in the cost issue was around payment. And some people like to critique the Massachusetts coverage law by saying, well, you already were so far ahead of the rest of the country. You already had low rates of uninsurance. But on the issue of cost and affordability, we were behind. Massachusetts, depending how you measure it, may be the most expensive place to get and deliver health care in the nation, which would then make it the most expensive in the world. So in some ways, we started from behind when it came to cost. So back at Blue Cross, after the law passed, actually right around that time, 2005 and 2006, we started saying, what can we do as the largest commercial payer in the state to lower costs and to improve quality? This was also at the time in the mid-2000s when the patient safety and quality movement was really gaining a lot of momentum, and a lot of its leaders were also in Massachusetts. So what we wanted to do was design a payment system that would improve quality and lower costs. And we did what any smart health plan would do when faced with that kind of challenge. We hired a consultant. So we hired a consultant and we said, scour the nation and find us the most effective payment model that will both improve quality and lower costs. And they came back with one of those thick 250-page reports, 50-slide deck that said there is no such model. Very disappointing, so we had to invent one ourselves. So we literally took a team of about 20 clinicians, physicians, nurses, reimbursement expert, measurement scientists, and we put them in a room. We called it the cave. In fact, when they came out, we gave them those kind of miner helmets, with the flashlights on them. Said, you must invent a new model. And here's what they came up with. So first, we decided that we had to move away from the fee-for-service system, that was by its nature inflationary, that if we were only going to pay for admissions and visits and activity and not pay for health, we had to change it. So if a primary care practice at one of our hospitals was successfully managing a group of patients who had a chronic illness, such that they were kept out of the hospital, we would pay them less. If they were not doing a good job and those patients were admitted to the hospital, of course we'd pay them more. If while they're in the hospital they contracted an infection that could have been prevented, we'd pay them even more again. Isn't that backwards? So we wanted to change that. So we started by establishing a global budget based on all medical services, medical care, prescription drug spending, now behavioral health spending. We developed a shared risk model, and we said you have to be on a declining trend as opposed to an increasing trend. For quality incentives, we picked 64 nationally recognized quality measures that were validated by the National Quality Forum, 32 on the inpatient side, 32 on the outpatient side. And we also wanted to try to disrupt that adversarial relationship between hospitals, physicians, and health plans, where every other year you have a negotiation about price, and we said, let's mutually commit to each other's success. Let's go into a 5-year relationship where we work together to improve the care and lower the cost of our members, your patients. So at the beginning, we had a few pioneering plans who agreed to do this, who came in, groups of primary care physicians, and over time, as you'll see, it is now the standard way we pay for care for our HMO members, and I'll come back to that distinction. So almost 90% of the primary care physicians and specialists in our network, which is all of Massachusetts, are now accepting this. It is the standard way of care. Now, you might ask, what happened between 2011 and 2012 that there was such a big jump forward? What happened was I sent a letter to all the physician and hospital leaders in Massachusetts and said, we have early results. They're good. We've seen, and I'll talk about our results in a minute, costs are down, quality is up. This is going to become the principal way that we contract with physicians and hospitals. We're not going to require you to do this. That was with the alternative quality contract idea. But we're going to keep our fee-for-service payments extremely low. Now, that letter was, as letters often are, leaked to the newspapers. And the next day on the front page of our major daily newspaper was Blue Cross CEO says, hold down costs or else. Became known as the or else letter. And although I didn't intend it this way, it had the desired effect, and there were some other environmental factors as well. And suddenly, as the fee-for-service system became less and less attractive, this new global budget system became more and more attractive. So this program, and at this point, it was called the AQC, Alternative Quality Contract. You know, we wanted to change the name because if we'd known it had been such a big success, we would have called it something like Blue Breakthrough or Blue Innovation or Blue Sky, because everything in the Blue Cross Blue Shield system should be blue. But it was too late. We sent it to our marketing department, but the acronym had already stuck, and it was called the AQC, and everyone knew it, not just in Massachusetts, but around the country. So it's not only one of the largest commercial payment initiatives in the country, but it certainly is the most rigorously evaluated. So a team of researchers at Harvard Medical School, led by Mike Chernew, have been publishing results on the AQC annually. And consistently, year over year, they've found that it increases quality and slows spending growth. And all types of provider groups are succeeding. So large groups, small groups, academic, community, urban, rural. Yes, there are rural parts of Massachusetts. Even practices, this was one of the big questions, practices that serve principally low-income, vulnerable populations have succeeded in meeting the targets. And these results, which were just published last October, cover the program's first 4 years. In the early years of the studies, for those who are interested in study design, we had a classic controlled experiment. We had groups in Massachusetts in the AQC and groups who weren't. By the time of the 4th year, so many that were in that we had to compare them to like groups outside of Massachusetts. And by year 4, compared to the controls, medical claim spending for patients cared by our physicians under this model were a full 10% lower, much of it from savings from redesigning care that I'll talk about in a minute. So what happened on quality? Well, a similar story, dramatic changes. And so the researchers observed over a number of different domains, I'm just showing you 2 here, that while national numbers stagnated, improvement, so that gray line you see in the slide stagnated, our physician practices improved dramatically. Some of our AQC groups, for example, had 9 out of 10 of their diabetics with blood sugars under good control. The national average is 70%. So that was the early results, but when we looked at our products that we offer to our customers, about a half of our members are in so-called HMO products, but the rest are in PPO, which is the more dominant form of insurance across the country. And we were getting a lot of questions from other Blue Cross Blue Shield plans and other plans saying, and including the government, saying, well, that's fine that you've done it in an HMO population where members, when they enroll, have to choose a primary care physician, but what about so-called PPO, freedom of choice plans? That's where the nation's going. And so we spent 2 years again back in the cave studying the problem, and we've now come up with a solution for PPO as well. And we announced earlier in 2015 they were expanding it, and a few weeks ago we announced that the first 4 groups covering about 250,000 of our patients, including large academic groups again and smaller community groups, are joining the new model. And as we did this, other local plans followed. And so now you saw the goal that Dr. Conway laid out about having 40%, I think it was 40% of payments in CMS nationally being in these alternative models by 2016. We're already there in Massachusetts, and so 40% of the commercial members are under these new models. So what have we learned from this work? 4 big learnings. And obviously, before I get to these, some things you've probably heard about: physician leadership and support is very important, changing culture. Having meaningful financial impacts tied to performance is very important. And that long-term investment, that mutual commitment was very important. But I'm going to focus on 4 learnings here. First, about support. So how have we supported our physician and hospital groups so they could be successful? Second, about what that's doing to the changing role of health plans like mine and physician and hospital groups. The issue that Dr. Conway talked about, attribution, which has been a big barrier. We've surmounted that, and I want to tell you how we've done that. And then finally, how we've changed the model over time. So the first has to do with support. So we provide our physician groups, next slide please, with daily, weekly, monthly, quarterly, and annual reports about how their patients are faring. Some are as simple as your patient was admitted last night to the hospital through the emergency room, and unless you're on a interoperable electronic medical record, you may not know it, to very detailed statistics about care patterns, about chronic illness, about practice pattern variation, about hospitalizations, et cetera. And these reports have been designed in collaboration with physicians and hospitals, and they're using them extensively in changing care as a result. But we're also doing support beyond the numbers. So it turns out there is a great desire for shared learning among physician practices and hospitals. And so we regularly convene groups of our physician practices together. Some of you may recognize that's Atul Gawande, the noted author, and a colleague of mine on the left, talking about end-of-life care and how that can be improved among these groups. We have separate groups of data analysts, case managers, medical managers, among all these groups coming together in shared learning experiences. And they also, of course, can call on our own physician leaders for communication and support. This kind of support and these kind of payment models, which have grown and flowered so well in Massachusetts, are now growing nationally within the Blue Cross Blue Shield system. We're very excited about that. And this is one of the strengths of the Blue Network nationally. And so now we have reforms like that. You're going to hear for a moment from Pat Garrity, from my colleague from Florida, others around the country. So we're actually knitting together a national network of these kind of payment reforms. So what does this do to the traditional roles, next slide, of plans and providers? Well, they may be changing. So most of you probably know that in the 80s and 90s, health plans like ours built up intensive, what we call care and disease management capabilities. Because of the fragmentation in the delivery system, patients often weren't getting the connections, especially patients with chronic illness, weren't getting the care they needed. As we start to pay on a global basis, on a population health basis, to physician practices, they're now taking accountability for a lot of that management. So the question is, should for example, a nurse stationed at a plan like ours be calling patients, reminding them about appointments, talking to them about chronic disease management, talking to them about wellness, or should some of that care be more logically placed inside the practice of themselves? So we're working on that. This evolution, I think, is going to change the roles. On the learning on the issue, I talked about attribution, and I know some of you are policy experts in the room and some aren't. But this is this key question that it may seem like a technical point, but payment reform can't work if physicians feel like they're being held accountable for the right, if they're not being held accountable for the right population. As we move from an HMO product, again, where patients choose their primary care doctor, to a PPO product where they don't, we needed to develop a way to assign or attribute our members to accountable groups. It took several years of working with physicians, and eventually we worked actually with other local health plans. We kept adding data elements to improve accuracy. It's now based on 2 years of claims data, and then we did an important thing. After assembling all this data, we went to physicians and said, are these your patients? And then we went to the patients and said, are these your physicians? And that was an important way to validate the model. In the end, we managed to achieve a very high level of accuracy that gave our physician leaders confidence that when we started paying in a global budgeted way and with population health for a group of members who have not chosen a primary care physician, they could say with confidence, these are their patients. Another learning was about changing the model and sustaining it over time. What we did was one interesting innovation was a few years ago, we started using each group's performance on quality measures to drive their share of the risk. So better quality scores meant they would have to repay a smaller share of cost overruns. Better quality scores meant they would have to also, they could keep a larger share of the savings. So we actually linked. So often in these models, the efficiency incentives and the quality incentives are separated. We were able to join them together in a unique way, and this innovation has been well received by our physicians. The other thing is you probably hear regularly when you talk to physicians about the kind of cacophony of measures that are out there, of quality measures. And so we've been very focused, so we've started to narrow some of the measures from 64 to 50, but more importantly, focusing on the next generation of measures. And one set of measures we're very excited that will be in our next model are so-called patient-reported outcome measures. So the patient's own experience, not their just experience of the care, but their functional status, the status of their pain, how well are they doing, their emotional health. And so we're going to be rewarding physician practices on some of those measures that patients care the most about. And then finally, as Dr. Conway said, we want to create, next slide, a learning culture in our organization. So we're constantly refining this model. So we now have 6 or 7 years experience, 4 of which have been rigorously evaluated, that we know it's working, but we know we can always get better. And so we've created a model that is flexible, where we can continue to innovate, but we believe we now have a chassis, a powerful chassis of collaboration between physicians and hospitals that is incenting better performance, higher quality, lower costs in a way that works for patients, works for caregivers, and ultimately works for those paying the bill. Thank you very much.